Welcome, Dr. Fu, and I just realized I have not made you a co-host so that you can share your screen. So that should be all set for you now.
All right, let me see if it works here. I am using both a computer and a phone. Can people hear me?
Yes.
Okay. It's been a very interesting session. Sorry, I was driving for part of the session so far, but thanks everybody for such a wonderful discussion so far.
Thank you.
Let me see if my slides will move here for me. Let's go.
So Dr. Fu, if you want to do resume slideshow up towards the top, or from beginning maybe.
Yeah.
Let's see.
Like I thought I already did that resume slideshow.
Or in the bottom right corner, to the right of, or to the left of, that thing.
Doesn't want to
Jillian
do
had
that for me.
That was the same problem I had earlier, which has never happened before.
It worked earlier.
Yeah, the good thing is the slide is big enough that even if it stays in the screen,
it's not advancing. That's a problem. Oh, there it is advancing. All right. So one, I just wanted to make some few disclosure. One, I may not speak as clearly and I may be a little bit more difficult to understand than the other speakers. Two, I may take longer than the 45 minutes that I plan to use. So if you have questions, just type them in. And if I don't pick up on that, just unmute yourself and ask that question as we go. I do hope to have some time at the end for us to discuss that. Three, I just want to mention that as we go through, we will see the great advances that we've made with hemophilia care. I think of this a lot of recent because when I hear people complain, oh, the COVID vaccines, they have not been tested in enough people. It's only 40,000 people. I say in hemophilia, sometimes we test 50 people and we go along with it. And that is what has really made us achieve the advances we've had in bleeding disorders, is that the bleeding disorders community has embraced science, and science has in turn really helped revolutionize what we do with treat hemophilia today. So before I move on to do this, one, I will talk a little briefly about the balance of clotting and bleeding, and then I will use a few slides to just run through the history of the development of treatment for bleeding disorders so that we know how we got where we are and hopefully where we will be tomorrow. Bleeding and clotting is a very delicate situation in the body. We don't want to bleed too much. We don't want to clot when we don't need to, because that will block up the pipes and then blood won't get where it needs to go. It won't live where it needs to live. So the body has done that by having a very delicate balance of clotting factors and bleeding factors, so that if we accidentally make clots, we can clear those very easily. But if we also hurt ourselves and there is a damage to the blood vessel, we can repair that with little blood clots very easily. And then the mechanisms built in to stop the system from going overboard, be it in the clot making situation or in the situation where you need to break down blood. So I look at it as we have a balance here. You have all these ingredients on the one arm, which are there doing their job, and the other hand here where you want to make clotting, you have all those ingredients there balancing out those which are trying to break down the clotting. Then you can have situations where that goes out of balance, and that is where we will focus today. We'll focus on bleeding disorders where the balance is tilted towards breaking up clots or not being able to make clots fast enough or in enough quantities. The one that we talk a lot about is, of course, hemophilia A, which is factor 8 deficiency, or hemophilia B, which is factor 9 deficiency. But all the other bleeding disorders that we talked about, and I will reference people who did not participate in the rare bleeding disorder event earlier today. If you get a chance, go and view that recording. I think Dr. Bryan did an excellent job, and there were very excellent discussions following that particular talk. So we will not go into details about rare bleeding disorders, but a lot was covered there. So we now have the balance is tilted against clotting, and we are bleeding more than we need to. So a couple of things can make that happen. One, we can have the clot breaking system to be too powerful. So I listed some of the proteins there. Some that we will talk about is anti-thrombin 3. That is a chemical in the body that really helps to break down clots when there are clots formed, or to slow down the process of clot formation. There are others, protein S and protein C. As we talked earlier today, a very big part of what blood disorder centers do nowadays is they're working to help those people who have clotting problems, so they clot too much. So let's look at what has happened over the centuries, or no, not really centuries, let's say decades, in the treatment of bleeding disorders. So treatment will involve situations where we say rest that area where it's bleeding, especially the extremities, the joints, then splinting, and then we have factor. In the last few years, we've moved into the non-factor regimen of treatment of bleeding disorders, and then there are, of course, surgical interventions for bleeding disorders. Then one key, and I think a more important part of managing bleeding disorders nowadays, even more than treatment, is really prevention of bleeding. So we want to avoid bleeding, and then even if people bleed, we want to prophylax so that they don't bleed anymore in the future. So I broke this down a little bit into different aspects, looking at how the different parts of treatments work. So we have a situation where, for example, we have that balance is off track because we do not have one of the clotting factors. So we have a weakness of the clot-making system, and this pushes the balance to go on the side where we are breaking down clots more. So one of the approaches we can do is to replace the missing factor. So we substitute the factor with something. So the next few slides will look at the strategies of substituting, so that if we add something more on this side, or we replace what's missing on this side, we are going to go back to this balance here. Again, we always want to get back to a balance. We don't want to overshoot on the other side, because bleeding by itself is bad, but too much clotting is not good either. So if we can also do that by weakening the clot breaking system. So we are missing something on this side. Instead of replacing what we are missing on this side, we take out something from this side so that we can go back to a balanced situation. So let's look at what has happened basically in the last century. If we go back to prior to 1920s, and in the 1920s, we did not have much to do when it came to people with bleeding disorders, especially hemophilia. All we could do was rest, and we could splint the joints. If it was extremities, we could splint them. And there was so much bleeding going on, internal bleeding, that life expectancy was horrible. Life expectancy was about 10 to 15 years for people with hemophilia A or B. By the way, the diagnosis was also very backward then. Then in the 1930s, that's when we really started doing more of blood transfusions, not just of bleeding disorders. With the world wars and the rest, there was improvement in blood products, blood transfusions. So people with hemophilia, they didn't have much choice. All we could do was give blood transfusions. Then we went quite a long time, and in the 1960s, there's a time we were able to do cryoprecipitate. So we were able to concentrate Factor 8, we're able to concentrate fibrinogen and von Willebrand factor, such that instead of giving you whole blood, we could give you concentration of those factors that we need. Then the 1970s is really the time when we had the factor concentrates. We developed technologies where we could concentrate factor 8, factor 9, and then DDAP was introduced in the 1970s as well. Then came the 1990s, which I think is one of the years that we really started making the big technologies that have come to revolutionize care for hemophilia. That's when we developed recombinant technology to be able to do recombinant factor. 2000s, there was not a lot new coming on, but this is when we consolidated that technology, the technology of recombinant factor. We were able to improve the purity of these factors so that the animal or human proteins that were common in the earlier versions of these factors, we got them out. And then in the 2000s, that's when we started some early gene therapy coming into play. This is also with these technologies that we're able to basically eliminate the discrepancy in life expectancy between people with hemophilia and the general population. And then the last 10 years in the 2010s has really been revolutionary in the sense that it has basically not just gone from us having extended half-life products, we're able to go into the non-factor products and then gene therapy. And then the future is out there, everything is possible. We are going to probably see a lot more non-factor products. We are going to see a lot of gene therapy. We are going to see optimization of a lot of things. And that's what we'll be talking about for most of this, for the most of the next hour. Before we go on to talk about all these wonderful things that we have, I want to make a side note here. I talked about the 70s, I talked about the 90s. I skipped the 80s. I think the 80s, some people will call it terrible 80s. In the 1970s, we had really gotten into doing plasma concentrates and getting all of these factors. But then came HIV and then hepatitis C and the difficulties of diagnosing it. For a long time, we did not know what it was, and we could not diagnose it, could not pick it up in blood. The way they did most of the plasma-derived products was pooling tens of thousands of units of plasma to concentrate factors. And then because of the poor technology we had then, unfortunately, some of these factors were contaminated with HIV or hepatitis C, so that thousands of people with bleeding disorders were infected with HIV. Some studies show about 7 out of 10 people who had hemophilia A or B ended up with HIV, and thousands unfortunately died. There are still a lot of people today who still suffer the burdens of the infections from the 80s. This, however, did also push forward the development of recombinant factors, but also improvement in viral detection and inactivation, so that since at least 1998, most data actually suggests that since 1992, there has not been any HIV or hepatitis C transmission in factor concentrates. I picked 1998 here because that's where the CDC, UDC data has very clear information that we have done very well since the early 1990s in preventing the transmission of HIV and hepatitis C with factor concentrates. So when we ask, what is the future going to look like? I think in the future, we are going to have a variety of products. I want to speak a little bit to regular half-life products, which in the last 20 years have really dominated the treatment of hemophilia A and B. Let's remember half-life, regular half-life, factor 8, has a half-life of about 10 to 14 hours, and factor 9, a half-life of 18 to 22 hours. I think in future, we are still going to need this for breakthrough bleeding. Some insurance companies do not really want you to use extended half-life products for breakthrough bleeding when you are on some of these non-factor products. We are going to use it in some people who have intolerance of other products. And I think that the industry may go to a point where they're able to formulate some of these products in a way that you could give subcutaneously. At least talking to some of the people in early development in industry, that is this technology that they are looking at. But overall, this category of treatment is going to decline in popularity in the years to come. I think 10 years from now, you have a very small group of people still using this factor. Again, we'll probably use it for breakthrough, and that very small population that doesn't tolerate other treatments. Extended half-life products, which in the last, I think 5 years had really been dominant. So given that most of the factors we had to be administered intravenously, so through the IV, the industry had really been looking at how can we prolong the half-life so people don't have to administer factors so often. But in addition, our expectations from treatment factors have increased, that we are not just looking at preventing bleeds while we are at rest, but increasing the activity and risk that people with hemophilia can take so they can live more normal lives instead of just being sedentary or being kept out of a lot of physical activity, which, as we heard in the nutrition talk, can lead to obesity and not so good for joint health. So the two main technologies that people use is what they call fusion technology, where they basically bind this to either albumin or some immunoglobulin. That's a compound that we generally have in the immune system. What this leads to is that the factor is recycled in the plasma, and this increases its half-life. The other technology that is used is they bind it to another compound, frequently something called PEG, which reduces the degradation. So the enzymes that break down the factor are slower in degrading factor when it's bind to this molecule. That again increases its half-life. The first extended half-life products were licensed in 2014. There was a factor A product and a hemophilia A product and a hemophilia B product that same year. So what have extended half-life products done? They have shown that they are very good at bleeding control. The annualized bleeding rate on these factors on average, when you look at the studies that they were done, is about 1 to 4 a year, significant improvement before that. They increased the half-life by 1.5 to 2-fold. So in general, you end up administering this factor about 2 times a week instead of about 3 times a week that we were doing with regular half-life products. This generally gives a trough, so the lowest level of factor that you have before you give the next dose of about 2 to 3% for factor 8 and 5 to 10% for factor 9. If we remember, by definition, if you have factor levels above 1, then you do not have severe hemophilia. So about 5, we call it a mild hemophilia. So these factors have been shown to be good and effective in both prophylaxis, so in preventing bleeding, and episodic management. So if you get bleeding, you can use these factors as well. What are some of the drawbacks of these factors? One, just like the regular half-life products, they have to be administered through an IV, either a port or an IV through the arm or leg. They have not, at least in the opinion of many hematologists, me, myself included, and I think a lot of our patients, they have not decreased the number of infusions as some of us had hoped. So yes, going from 3 to 2 is an improvement, but it would be good if we went to even less infusions. There is certainly a concern that when you are giving it and it has extended half-life, when you are using it for breakthrough, do you increase the risk of overusing it or not? And then, of course, some insurance companies push back, since these products are generally more expensive than regular half-life. If you use it for breakthrough bleeding, they think that the costs go higher for them. we have started using this product in patients who are not been previously treated with factor, but most of the studies were done in patients who had not had inhibitors before. So there is some risk that over time we may run into a considerable number of patients who may develop inhibitors since they get exposed to this factor up front. Then there's a question of pegylation, so binding it to this particular molecule, if that is a risk. I want, because people ask this question frequently, pegylation is not new. So this PEG molecule has been used for many other medications for decades, and it's been shown to be safe. What we do not know, though, is if you have hemophilia, then you are going to be getting this PEG molecule for, if you stayed with it the rest of your life. If you get pegylation, like what we use PEG for a medication to increase your white blood count, for example, you may end up using 10 or 20 doses if you have cancer. Now, for hemophilia, if you're doing it 2 times a week for 80 years, is it just as safe? We do not know, so we will need to know with time. The other thing is that in the United States, we do not have this restriction, but the European Medical Agency was concerned enough that pegylated product are approved only for people who are 12 years and older. So that's something we are going to see with time. So with some of these concerns, what do I think is the future of extended products? I think they will likely have a decreasing use in future, but they are going to be a good amount of use in the next few years, but their use will be decreasing as a non-factor product use expands. I think these products are going to be optimized by the manufacturers, and they will deliver better than they do today. So I think the half-life will become extended, and just like the other factors, I think they will try to come up with ways of administering this through a subcutaneous administration, so you don't need an IV. Then what is really in vogue now, and what I really wanted to put in a lot of time to today, is the non-factor programs which are ongoing, some of them which are already in use today. So in general, we are looking at products which can mimic the coagulation factor. So you don't have factor 8, you don't have factor 9, or any of the other clotting factors, but you come up with something that can interact with the body system to make blood clots, so that you generate a blood clot even though you don't replace that factor. One of the big technology that's been there and has made a lot of progress is a monoclonal antibody. So these are basically like other antibodies which are generated, and they are specific to certain proteins in the body. You would have noticed I'm trying to avoid mentioning medications by name, since there are so many, but there are some which are just so dominant in their categories that I will mention them by name. One of such is emicizumab, also known as Hemlibra. And then the other one we are going to mention is concizumab, which is still in clinical development. So the way I look at this is it belongs to that point where we know there is an imbalance. Instead of replacing that factor that we have, we substitute it with something else, but that still helps to bring the balance into position again. It's almost the same looking at, you come to Greenview, Beng Fuh is not doing his job, and you say, okay, instead of going and looking for Beng Fuh, we'll look for Dr. Davis. Dr. Davis comes, she does the job, and things are just as fine. So that's what some of these non-factor products will do. Let me move. So before I talk a little bit about emicizumab, let's talk a little bit about what does factor 8 do. So one of the main jobs of factor 8 is to play a matchmaker between factor 9 and factor 10. So It comes here and it pulls them together, activated factor 9 and factor 10, pulls them together, and now they can activate each other and they trigger the thrombin production. So in this case, in hemophilia A, you do not have your factor 8, so you cannot get activated factor 8A. So what the antibody does is the antibody has both an arm to make friendship with factor 10 and has an arm to make friendship with activated factor 9. And when that happens, it's now like, okay, both of you are my friends. Then the antibody here pulls both of those friends and say, okay, I want you now to be friends with one another. And then they say, okay, you're the friend of this guy, I'm the friend of this guy, so let's be friends. So you have factor 10 and activated factor 9 that come together, and you are able to achieve what normally factor 8 would do. So factor 8 becomes irrelevant. So imicizumab went through studies and was found to be very effective and was licensed in the US in 2017. It is used in patients with factor 8 or hemophilia A as with or without inhibitors. So initially it was very good for inhibitors, but it was very good, so they moved it on to patients who do not have inhibitors. It is administered subcutaneously, so there is no need for you to have an IV or have a port. There are several regimens. You can administer it once a week, every 2 weeks, every 4 weeks. The every 2 weeks shot some of the best results that there were. The once a week dose is about half of the twice a week dose, and the twice a week dose is about half the every 4 weeks dose. Children generally we give every week or every other week dosing. In general, as you know, hemophilia in children, they end up needing more frequent dosing than adults, but most adults are able to go to every 4 weeks dosing. When you look at all the studies that were done for Hemlibra, the annualized bleeding rate was excellent. So it was less than 1, some studies were 2.9. The every week and every 2 weeks, most of them had annualized bleeding rates of less than 1 bleed a year. And of all the 4 studies that were published, you have 0 bleeds. So those who had 0 bleeds, they were about 60 to 90% of all those in the clinical studies had 0 bleeds throughout the study period. So they're very excellent studies there. So what are some of the concerns? It sounds very good, and this seems to be an excellent product, but there have been some concerns that have been noted since this product got on the market, and some from the studies when we started using it. So we've seen some microangiopathy, so tiny blood vessels having little clots in those blood vessels. This has mostly been in patients who are getting the Hemlibra for their prophylaxis, and then when they get breakthrough bleeding, you give them regular factor. So it seems that when you have this state where you have Hemlibra in the system, and then you give other factor to help control bleed, it increases your chance of having small thrombosis or injury to the tiny blood vessels. Imicizumab has not been studied in previously untreated patients. So all those who were in these trials were those who had been on factor before, and then they were transitioned over to being treated on Hemlibra. So the question is, if we, and in future, as we move people who have not been treated with factor before, and we start them directly on Hemlibra, if they get a breakthrough bleeding while they're on Hemlibra, you will have to treat them with regular factor. And when we give regular factor, we know that for factor 8, for example, up to 1/3 of them may develop inhibitors. So if somebody develops inhibitor while they're actively bleeding or in surgery, it's certainly going to be more challenging to handle than if they had developed inhibitor when they were on prophylaxis, and you have time to come up with alternative ways of managing, and you are aware of it. So these are things that generally I think individuals with bleeding disorders who are on Hemlibra, especially if they were not exposed to factor before, need to be aware of, and the doctors and hematologists certainly are aware of or should be aware of. Then the next question that a lot of people have and have not, these questions have not been effectively answered, but hopefully with time we will have answers to them, is factor 8 we know is very important in mediating that contact between activated factor 9 and factor 10 to make you develop that clot which you need. But there are other things that we know factor 8 is very helpful for. For example, it helps with wound healing. And then we know even when you bled, having people on factor 8 and factor 9 for that matter, it helps with preservation of joints. So it's going to be a matter of time before we know how efficiently these replacement products of factor 8 or factor 9 or another clotting factor for that matter, also in addition to helping generate the clot, help with these other things that the clotting factors do. And I've been in medicine long enough. There are always things that we think we know and we do not know for sure. The time tells us that we did not really know as we thought we did. So there may be things that factor 8 or factor 9 or other clotting factors do that we do not know. We've always focused on their duty in making a blood clot. There may be other duties that they have that 10, 20 years from now, we'll say, now that we are treating with non-factor product, oops, this thing is happening. It was probably a function that was performed by factor 8 and it's not being performed now. So we can also manage bleeding disorders by saying, okay, since this arm of making blood clots is weak, let's weaken the arm that breaks down blood clots. The next two medications I will talk about do exactly that. So one of the things that the body uses to control or decrease how much clot we make is something we call the tissue factor pathway inhibitor. So this is part of the system that sits on the blood vessel here. So when you are there, tissue becomes exposed, it activates the body's ability to make the blood clot, and then you have the tissue factor here, which mediates that. Then the body has this inhibitor, which comes, and so you have here your factor 8 here and factor 9, they are hanging out and they are being activated, and that releases a factor 9 to continue the activated factor 9 to now go work with factor 10 to activate that. When this tissue factor inhibitor comes and binds onto them here, it stops this from the activated factor 9 from being released. If that's not being released, then you cannot make a big clot. So that is how the body prevents excessive clot making. So what the mechanism here says is we have a problem with making clots, so we are going to go and handicap the body's ability to stop excessive clot making. So what this compound does, you have these antibodies, it comes and binds this here, and when it binds it, it stops it from attaching itself here and stopping the release of this activated factor 9. So we have this is what the body does to stop activated factor 9 from being generated. So we say, you stop doing it so that activated factor 9 gets generated continuously. So though we do not have a lot of it here, anyone that is generated, any factor 9 activity that's generated here can continue to produce activated factor 9. By so doing, we increase clot formation. So concizumab is currently in a phase 2 clinical trial, and it showed very good tolerability and safety. It was so good that the FDA last year, at the end of the last year, gave it breakthrough therapy designation for use in patients with hemophilia B who have inhibitors. Again, they picked hemophilia B because for hemophilia A, we already have Hemlibra. So for those who may have hemophilia B with inhibitors, they will know that it remains a very challenging thing to treat. You still have to use bypassing agents for that. We have not yet had any product that really targets that. So based on that, there is big need for a product there, just with phase 2 clinical trials that can be used for people with hemophilia B who have inhibitors. There's an ongoing phase 3 clinical trial, which is looking at both hemophilia A and hemophilia B with and without inhibitors. So as we can see, Hemlibra was there working mostly to enhance collaboration between factor 8 and 9. So it is for people who have hemophilia A. But this one, because it's working at a higher level, you can use it for hemophilia A or hemophilia B, and actually several other bleeding disorders, because it is further down in the track where your body makes blood clots. Again, the advantage is that you don't need IV, it's administered subcutaneously, but unlike Hemlibra, where you can give once a week, once every 2 weeks, or once a month, this one so far in the studies has to be administered once a day. Then another product that is in clinical development actually targets anti-thrombin 3. So as the name says, it's a protein that goes and decreases your ability to make thrombin. Thrombin is really what is the first stage of the blood clot. So there's a blood clot that you make, and then it gets solidified to heal that area. So you can now go and reduce the body ability to make the anti-thrombin. That way, any thrombin that you generate will stay around. So that increases your thrombin and stabilizes your blood clot. This is a little tricky here, and I know it's difficult to read all of this, but it's really not important to do that. It's just to show some of the technology that's being used. So I'll just back up. One of the things that we really found out in the early 2000s was a lot of knowledge on how the gene works, how the body makes proteins from our DNA. So one thing that came out, and one of the person who won the Nobel Prize in 2006 for medicine actually had worked on this called small interfering RNA. So we found out that there's some molecules of RNA, which is a different form of DNA. It goes and blocks certain genes so that they cannot be transcribed, so you cannot copy them and make protein with it. So what this medication does is basically, this is a synthetic RNA that you are able to traffic. There's actually part of it that helps it to traffic, go into the cell, and that part then get kicked off. Then the other part goes and it binds the area in our DNA that produces the anti-thrombin 3. So when it does that, it blocks the production of your body from making much anti-thrombin 3, and you're not making a lot of anti-thrombin 3, then your thrombin here will stay in higher numbers, and that thrombin is what helps you to make a blood clot. So this medication called fitusiran basically is that you inject it, and then it goes into the cell and reduces that and tries to balance the scale so that instead of you bleeding a lot, since you're not able to break down your clot, that scale goes to where you are not bleeding too much. This medication is currently in a phase 3 clinical trial. Again, phase 3 clinical trials are the final trials where you are looking to show that that treatment is not inferior to your current treatment. So they are looking at treating both hemophilia A and hemophilia B with and without inhibitors. It is administered as a subcutaneous injection, just like you would do with insulin. It's once a month administration. And the annualized bleeding rate is very low, about 1.08 in the study patients. I will be remiss if I do not mention that this product had been in development for quite a while. We actually had that study open here. There was a fatality in 2017 of somebody who was on this study. That person had developed a thrombosis, so a blood clot in some of the veins in the head. And because this product was actually the first in the line of this category of products, we did not yet know a lot. So that study was put on hold for a while and it was reassessed. So after they looked at it, they came up with things to be put in place to make sure that those things can be controlled. I will make a few more comments on that in a few seconds here. So concerns is, how do you manage breakthrough bleeding? And when you manage a breakthrough bleeding, what is the risk of thrombosis? So they have now, for example, Anti-Thrombin 3, which you have for emergency use if somebody has concern that they're having too much blood clots now. So in my opinion, this is a paradigm shift for those who treat hemophilia over people who have hemophilia, that instead of being worried just about bleeding, you need to be worried that you may clot too much. So to illustrate this, I will tell the story of this one fatality that they had. So this patient was away on vacation and developed severe headache. And being that they had hemophilia, everybody thought, okay, they must be bleeding. So they gave factor. That patient actually had a brain imaging, a CT scan at some point. They did not really pick up that they had a clot in the head. So everybody said, no, we are not seeing a bleed. As we have always been told, if you have a bleeding disorder and there's concern that you may be bleeding, we give factor. They gave more factor. So that probably went and worsened the thrombosis. And by the time they figured out that this patient had a thrombosis, it was too late. So really, not just for this fitusiran, but all patients that we are using non-factor products, including Hemlibra, we have to always have the back of the mind that we may actually push people more towards clotting too much. So in addition to thinking about bleeding, we think about clotting, and that may be something that needs to be managed. And again, just as we mentioned with Hemlibra, when we start treating patients who have not had factor before, when they get breakthrough bleeding, we may run into a situation where they develop an inhibitor in the middle of a serious bleed or after surgery, and we need to have contingencies in place to handle that. So what do I think is the future of non-factor products in the management of bleeding disorders? I think their use is likely going to increase rapidly. Many here will testify that Hemlibra has had a very rapid uptake in the last 2 years. I think their half-life will be optimized so that we will go to a point where you may need to get it every couple of months and not even every couple of weeks. I think there will be a lot of improvement in supportive care. We are going to probably have guidelines of when to be worried about thrombosis, what to do in those cases, how to better give additional factor in breakthrough bleeding to make sure we have a better balance of that. But I think this is probably going to be what dominates in the next few years. As that dominates, I think the other things right in the horizon. So we talked about replacing the factor. We talked about replacing the factor with something that is not a factor. I think the Holy Grail is really teaching the body to synthesize okay. Were participants not able to see my screen earlier?
We can see it. It just froze for a second, but we can see and hear you now.
Okay, sorry about that. So we look at synthesizing the factor, so to bring it into balance. And that brings us to what I think is the holy grail of everything hemophilia, is gene therapy. We know that factor 8 gene or factor 9 gene or factor 13, you could pick factor 7. If those genes are not working well, you will not make any factor, or you will not make enough of that factor. So a gene therapy gets you a good working gene into the cells so that it starts making the factor. Most factors are usually made in the liver, so a lot of the gene therapy is targeted at getting those genes into the liver. The hope is really non-integrating approach, so you get it, we will not go deep into that. So you can have the genes integrate into your DNA, though they can just be episomal, they're in there, they can be used to make factor without necessarily changing your, getting into your DNA directly. It's always been easier for factor 9 because factor 9 has a smaller gene, but factor 8 now has been successfully done mostly by deleting the B domain. That's part of the factor 9 gene that is really not that, factor 8 gene that's not very active. In general, they use a vector. A vector generally is what carries the material into the cell. Vectors that we use are generally viruses. And I know it sounds scary. We are going to put a virus into you. Now they generally will take out most of the viral genes and they use just a part of the virus gene that helps that virus to get into the cell. That way it goes into the cell and carries the gene of the clotting factor that you want to generate. AAV stands for adenovirus associated virus. Adenovirus is a virus that causes a cold, very common virus. Another virus that is used is a lentivirus. There are many clinical trials ongoing. I will give you an idea of some of those. So hemophilia B gene therapy was first performed on a study that is jointly sponsored by the Royal Free Hospital in London and St. Jude's Children's Research Hospital. The first patient was treated in 2009. So there are about 10 patients on that study, and in general, you have a 90% reduction in bleeds. More than 10 years out, the patients still have about 2 to 5% factor activity. So that by itself is very good, though when we look at what our expectations, some of our goals, so hemophilia getting that factor higher, some will say that's not quite where we want it to be. So what are some of the concerns with gene therapy? Is one, gene stability. How long is the gene going to be? This is something we will only know with time. Looking at the St. Jude's and Royal Hospital study, we are more than 10 years out, and that gene is still stable. And why is the concern about gene stability is because the liver cell turnover. So about 10% of adult liver cells will be turned over annually. And when the cells are being turned over, cell multiplication of the liver, does it also replicate the genes that you put into those into the liver? We think those which are within the DNA will be replicated or move on to the new cells, but those that are just in the what we call episome may not. The other concern is that your body may develop immune response against the virus. And if that happens and you knock out all the genes that you have, it may become tricky if you need to be retreated with gene therapy because your body may not tolerate that virus coming in the next time. And then, of course, when you have some of the integration of the virus in the DNA, can it get into parts of your DNA that can increase your risk of cancer? We think this treatment is going to be optimized and will be modified, and is probably going to become the dominant treatment of the future. There are other gene replacement approaches which are being studied. So where, for example, they take out cells and modify it, put the gene into it, and then they are transplanted, almost like you would do bone marrow transplant into the liver. And these cells will secrete the missing factor. There is a clinical trial, early human clinical trial ongoing with this particular approach right now. Then gene editing, again, the concept which is ongoing for certain medical conditions. There is not an advanced clinical trial for hemophilia right now, is instead of you trying to replace that gene, you go and edit it, almost like you go and you put you erase a letter in a word and you change that letter so the word is spelled correctly. again, this is in very early stages of development. So just a few words to rare bleeding disorders. Again, what has happened in the last 10 years is that more and more drug companies have developed factor concentrates for these rare bleeding disorders. In the 1980s and 90s, it was focused on hemophilia A and B and von Willebrand disease, but more and more they are coming up with factor products for these other rare factor deficiencies. I think as especially gene therapy and non-factor product take over hemophilia A and B, there will be an incentive to develop factor products for the other rare bleeding disorders. As we see the monoclonal antibodies and non-factor products, a lot of them are not specific to hemophilia A or B, so you will be able to use a lot of these for a lot of the other rare bleeding disorders. And this technology where they're using small interfering RNA, it's going to be refined and we'll be able to use a myriad of other diseases, including bleeding disorders. And then one field that's really very exciting ongoing is using nanoparticles, which are very tiny particles. You can get little molecules into it and get into cells. This is going to become part of the treatment that we use in future. So, as I mentioned, one of the things that has really moved hemophilia care to where it is a willingness and readiness of the bleeding disorder communities to participate in clinical trials. It has moved life expectancy from 15 years to regular life expectancy, has moved people from being able to just say, okay, I'm not bleeding, but I cannot play soccer, to where people can play soccer and they are not bleeding. And so if you want to see all the tens of clinical trials going on in hemophilia, you can go to clinicaltrials.gov. If you type in hemophilia, it will pull up all the clinical trials that are ongoing. And I think all these clinical trials portend a very, very bright future for hemophilia. I think we are going to get to a point where, especially for hemophilia, most patients are cured in infancy using gene therapy or one of the other exciting approaches which are around. We will eliminate chronic complications in people with bleeding disorders. And there will be more focus on the rare bleeding disorders. And I think we will need to pay a closer attention to females with hemophilia. We are moving away from just saying carriers of hemophilia gene, but looking at their bleeding complications, which will probably not be able to say, oh, let's do gene therapy, but those are some of the things we will occupy ourselves with. Looks like I made it, and I have 5 minutes. Hopefully we can have a discussion.
What questions do y'all have? Did you learn something new?
Dr. Fu, thank you so much.
Definitely. I really appreciate it because it was explained. Oh boy, that was a lot of information. That was good. Thank you.
Yeah, it's always a little tricky when you're some of these things, you don't know how much science to put into it and how much to just try to say this is what they are doing. So any feedback on how we can do this in a way that it's enough information, but not too complex is appreciated.
And we are recording, so you can always go back and watch and absorb a little bit more. I forget what the percentage is, but I know they say when you go to doctor's appointments and get a lot of information thrown at you, I don't know if it was 30%, but you barely take away a lot of that. So I'm sure it's similar with this, where it's just so much. So that's why we wanted to record it. But I did hear someone else also about to say something. I didn't catch who it was though.
Beng Fuh, could you tell us a little about your background? perhaps where you grew up, where you studied, and what you studied?
Oh, so I grew up in Cameroon. As you said, grew up. By the time I was 17, I think my mom was tired of me. She kicked me out. So I went to Germany. I studied in a town called Marburg. So for those who don't know, most of the human pea in the world is made in Marburg. So CSL Behring is based in Marburg. I studied there, and after medical school, they were tired of me. So I came to the United States, did residency at Children's Hospital in DC, went to Nationwide, Ohio for fellowship. And I have been here at ECU since 2007.
Okay. Is Marburg where the big castle is?
They have a castle. It's on a hill, very beautiful castle. It's not the biggest, but for those who are a little bit into Reformation, Martin Luther, the Reformator, not Martin Luther King, Martin Luther, the Reformator, he met in Marburg to discuss the 95 Theses before he posted them in Wittenberg in more eastern part of Germany. So that's another history of Marburg. It has the oldest non-Catholic university in Europe. So back in the Middle Ages, the Catholic Church controlled all institutions of higher learning. But the Duke of Marburg back then was liberal enough to say, anybody who thinks that the earth is not flat can come to Marburg and they can study there.
Oh. And Dr. Fuh, we had another question. Do you know if there's been any reports of cancer with the current gene therapy? The gene therapy in sickle cell has been on hold due to cancer.
No. So luckily, there has not been that reports of cancer in gene therapy with for hemophilia. The gene therapy in sickle cell that was held, the patient developed AML. It was a lentivirus. So luckily at that time, we did not have it. So the other trials that were using lentivirus were put on hold, but the AAV studies have not shown that. So no, we do not have a report of that for the hemophilia gene therapy patients.
Great, thank you. And I did have to, I've been moving around trying to troubleshoot and download earlier recordings and stuff. So I may have missed this, but do you know for folks, I see there was a slide about rare bleeding disorders, but I missed that part. So if you already said this, you can just let me know that and I'll watch the recording later. But for folks who have other rare conditions, do some of the things, because hemophilia seems to be at the forefront of these groundbreaking treatments. So is there potential for other bleeding disorders within what's happening for hemophilia? Does that question make sense?
It makes sense. I think that if you look at the mechanisms that they're targeting for hemophilia now, a lot of those treatments will be useful for some of the rare factor bleeding disorders. Where there is not a lot of activity is like platelet function disorders. There has really not been much there, including things like Berners-Soulier gland thrombostenia. There has not been much movement there. But when you talk to the scientific people at the drug companies, when they come to talk to us, there's a lot of interest in moving in that direction. So I hope in the next 5 to 10 years, because sort of the hemophilia field is being saturated, they're really looking at moving into that. So I'm very hopeful that in the next years, we will see development in that area.
Wonderful. Thank you very much. Really appreciate it.